All right, here we go. This is the Hall technique. Thank you so much to the folks at New Smile for being forward thinking and allowing us to have this talk today on Hall technique. Okay. And as Mike mentioned, I am a private practice pediatric dentist in the metropolitan Phoenix area in the United States, in a small city called Glendale. That's where the Arizona Cardinals play. So just outside of Phoenix. I did my dental school training at the University of Southern California, finished there in 2003, and then I did a hospital-based pediatric residency in Las Vegas, finished there in 2005. And I've been with my private practice ever since then. Our practice has been around over 40 years in the Phoenix area. And most of the staff has been there longer than me. So we've been through quite a few changes over the years. And just for disclosure purposes, I don't have any owner interest or stock in any of the products that I'll mention today. I don't receive any sales commission for sales of any products. I do, however, receive speaking honorarium to give lectures, including this lecture. And I have received honoraria in the past from various dental meetings, dental organizations, conferences, and corporations such as Elevate Oral Care, Oral Science, GC America, DMG America, New Smile, Dry Shield, and Procter & Gamble, none of which have any input on the content of the presentation today. All right, I am a big supporter of organized dentistry. I feel it's extremely important, perhaps now more than ever before, that we show our support for organized dentistry so we can have our voices heard, especially with what's going on right now. So whether that's through your membership or if you can participate in a committee, like I'm on the committee for our state Medicaid, and I've advocated at the state capitol, but whatever you can do to help get involved, it's greatly appreciated and very, very important. We definitely have strength in numbers. And just a shout out to my kids on the left, that's Charlie and Sabrina. They're now 8 and 10. My darling husband, who's incredibly patient, is homeschooling them, and we're just trying to survive in this new reality that we're in. Also a big supporter of humanitarian efforts and participating in charitable dental organizations, giving back our time and talents to those who are less fortunate. Such a rewarding thing that we can do. And needless to say, I would definitely like to cancel my subscription to 2020. Ooh, what a year. This is my office. Ooh, this was St. Patrick's Day. Not a very fun St. Patrick's Day this year. It's such a strange, eerie sign to have this on our door, to see the office empty when it's usually filled with people and smiles and laughs, and I miss my work family, and I miss my patients. It's tough, and I know we're all going through this right now, and there's a lot of uncertainty and a lot of unknown of when we're going to get back, but I know eventually we will. I have become known lately as an advocate for minimally invasive dentistry, which is the topic that we're going to discuss today. And I do get asked, why am I so passionate about this topic? But at first, I want to make a disclaimer. I am a clinician. Like I said, I'm in private practice, and I do consider myself a forever student. I think we need to be humble in acknowledging that science is ever evolving, and we need to keep on top of it. I also like to explain how I got so passionate or involved in speaking about minimally invasive dentistry. There's some key life events that changed the way I practice. One was becoming a mom. Specifically, my daughter had surgery under general anesthesia as an infant, and that dramatically impacted the way that I empathize with parents during the informed consent discussion. Especially when I was recommending sedation or general anesthesia for their child's dental treatment. I also experienced a medical emergency with an IV sedated patient in my practice. He recovered, he's fine, but in that moment, it was really scary. It was a wake-up call, if you will, for me to really examine what I was doing. And just my general observation over the years out in private practice, where typically we're seeing these kids from the time they're toddlers until they go off to college, where I saw that what I was trained, this more aggressive approach to treatment planning that I was trained in residency, didn't exactly equate to improved oral health. And it just made me question what I could do differently and what I could do better for my patients and for their families. And part of that was just recognizing the fact that caries is a chronic behavior-driven biofilm disease, and we're never going to drill our way out of a biofilm disease. While the treatments we do are very important, they don't cure the disease process, so we have to recognize that. And as a pediatric dentist, what is particularly concerning to me is the fact that we see these high relapse rates of what we think of as gold standard pediatric restorative dentistry, what's done in the operating room or under general anesthesia, where you eliminate any of the variables that could potentially negatively affect your treatment. Like you don't have a moving patient, you have ideal isolation, et cetera. But regardless, these kids are coming back, whether it's 6, 12, 18 months later, and many of them have either recurrent caries or new carious lesions, and that's concerning. This is an article from the AAPD journal back in 2015, where they concluded there's lack of substantial evidence to suggest that restorative treatment leads to acceptable long-term clinical outcomes. And there's certainly a need to go beyond the drill and fill dentistry and integrate other concepts of disease management to ensure long-term success. And, just not to get too controversial, because I do recognize there will always be a need for sedation, general anesthesia, and IV sedation in our pediatric practices. Unfortunately, many of these kids get to us when it's simply too late, and they have severe early childhood caries, they have infection, pain. These bombed out mouths is the term that we use, where unfortunately they're beyond the point of the minimal intervention, and you have to do the pulpotomy, extraction, et cetera. However, if we can get to the kids earlier, establish the dental home earlier, focus on prevention and education, if we could use minimal interventions as a first line whenever possible, and hopefully reduce, delay, or even altogether eliminate the use of anesthesia, I think that would be a great thing. And this is a topic that has come up frequently over the past 5 years or so, because there have been a number of highly publicized dental sedation related deaths in the media, which unfortunately casts a dark shadow over the entire profession, which is so frustrating because it's such a rare thing. It's that lightning strike. It's that 1 in a million. But when you get blasted all over the media, it creates fear in the parents. I mean, that's the reality of this digital world that we live in. And, we just keep seeing that. This was a few years ago in my own state, where this was all over the state media, the local media, as well as national media, where this little 2-year-old boy passed following a deep general anesthesia at a clinic. And the same week that hit the news, the U.S. Department of Justice also announced a $24 million settlement against the Cool Smiles Clinic, which is where one of the locations that this tragedy occurred, which just, talk about bad timing and bad PR for our profession. And it's frustrating, because I know that most of us are doing the best that we can to the best of our knowledge to help patients, but it's the rare tragedies, it's the rare bad apples that create doubt and concern with the public. Now, we also want to look at what our treatments are doing and if they're actually improving health. What's the outcome of what we've been doing over the past several decades. So this is an article that looked at this. The Healthy People Initiative reported that from 1990 to 2010, the percentage of children with untreated decay remained virtually unchanged at almost 30%. And it's significantly worse in underserved populations at about 50%. However, during that same time period, yearly governmental dental expenditures for children increased from $1 billion to $7 billion. So people aren't getting, their oral health isn't improving, but the spending is definitely going up. And spending is expected to reach $15 billion by 2020. I am sure that number will be skewed this year now that we're shut down, right? But the point of this is the data indicates that oral health is not improving in concert with spending. Minimally invasive treatment options like SDF, Hall crowns, atraumatic restorative treatment, et cetera, they are increasing in public awareness and demand. Today's parents, whether we like it or not, they're researchers, they're going online for their advice versus seeking advice of family or their doctors, which can be very frustrating, but that is the reality of the world we live in today. And now we have this new concern. You know, 3 months ago, parents were more worried about, say, cost or risk of sedation, et cetera. Now we're worried, now we're in this COVID-19 world. We have this invisible threat, this virus, and we're not really sure exactly how, is it droplets? Is it aerosols? Are our offices safe? How can we protect ourselves, our patients, our staff? There's so much unknown, which is it's an interesting time, but what is it going to look like when we finally get back to our practices? This is a colleague of mine in Texas doing emergency treatment recently. And if you think back before the mid 80s, before HIV and AIDS and the change to our PPE, where we started routinely wearing gloves to protect ourselves from bloodborne pathogens, I remember in dental school seeing images like this of bare-handed dentistry. And I remember just being kind of grossed out by this image, especially the hair on the fingers and sticking the bare fingers in people's mouths. Or here we have the dentist and assistant working without gloves, without masks. And I look back at that and think, ew. But I wonder, in this post-COVID world, what is our PPE going to look like when we get back? Are we going to look at what we were doing, let's say February 1st, 2020, look at pictures of that and think, oh my goodness, how come we didn't have a hairnet? Why didn't we have an N95 mask? I don't know. That's yet to be seen. Shout out to Dr. Jeremy Horst for this slide, looking at aerosols. This is our new concern. They've always been around, but with this particularly virulent and particularly contagious novel virus, coronavirus, we do need to be concerned about aerosols, which is part of the reason the American Dental Association and CDC recommended us closing our offices except for true emergencies. But even a simple toothbrush prophy creates and releases aerosols. So we need to be aware of that. So learning and innovation go hand in hand. The arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. So I'm hoping that in this time of social distance and self-quarantine, that we can use this time constructively to improve our understanding of the disease that we treat, improve ourselves as practitioners to catch up on the literature and the evidence, and reflect and introspect on what we could do differently and what we could do better as professionals. So, you're here today to listen about Hall crowns. So obviously you have interest in potentially adopting some minimal interventions, which is great. It's not going to get rid of anything you've done. Those will always be there in your toolkit, as we say. This is just adding in a new trick. And there's different components that come into play into adopting minimal interventions. Of course, there's the evidence, which is critical, what's happening in organized dentistry and academia, patient awareness and demand, and then economics. Now, if we look at organized dentistry in our American Academy of Pediatric Dentistry, this is a statement from their guideline on caries risk assessment. It is now known that surgical intervention of dental caries alone does not stop the disease process. Additionally, many lesions do not progress and tooth restorations have a finite longevity. Therefore, modern management of dental caries should be more conservative. And this is from the ADA journal, and the great Dr. Margarita Fontana from University of Michigan, who's one of the great caries experts in the US and, well, globally, in my opinion. And I really like what she had to say here. Although extensive efforts have been made to teach and perform caries management under a minimally invasive, that is non-invasive and microinvasive approach that emphasizes clinical and public health preventive services, the drill and fill approach may still remain predominant in some settings, neglecting to fully address the underlying disease process. Over the years, experts in the field of cariology conceptualized that caries acts as a recurrent disease cycle that involves varied states of demineralization and remineralization over a patient's lifespan. This concept is the crux of modern day caries management, a patient-centered, risk-based philosophy that prioritizes prevention, early detection, and non-invasive and micro-invasive treatments. Absolutely. So your homework assignment, if you haven't already read this, if you've been on some of my other webinars the past couple of weeks, you've probably seen this. So this is open access. I'd love if everyone could read this, but just looking at caries as a biofilm disease and an imbalance or dysbiosis in the biofilm. Okay, that's really the driving force here. So again, my personal stance, take nothing out of your toolbox. Hall technique is just gonna be a new trick. And I think you'll love it. I still do everything. Well, not right now, I only do emergencies, but whether it's sealants, fillings, crowns, extractions, I still do all of that. And it's not saying you have to get rid of anything that you do. But by incorporating minimally invasive treatments like Hall technique, I have been able to dramatically reduce the amount of sedation that I'm doing in my private practice. We no longer offer in-office IV sedation. I rarely have the need to refer out for general anesthesia, maybe a handful of kids during the year, whether it's due to medical reasons or parent preference, because it's their choice and their child, rare. And I am seeing Medicaid patients in Arizona, which has some of the highest caries rates in the nation. So I do see bombed out mouths, as the saying goes. But I have been able to dramatically reduce the sedation. We're doing about 67% before I started really incorporating these less invasive treatments. So just think of it as a element of informed consent when you're offering a minimal intervention. So if and when it's clinically appropriate, we should give that minimally invasive treatment option because our due diligence our moral ethical obligation is to review risk, benefit, and alternatives to treatment, including no treatment. And what I have found that I think is one of the many benefits of minimal interventions is when I offer minimal interventions, I found that it dramatically reduced the number of patients, or what I call the mysterious disappearing patient. It really improved our patient retention because we offer something for everyone. In the past, when I would just say, okay, here's your surgical treatment plan with sedation, take it or leave it, people would maybe smile and nod and then disappear, and they wouldn't return calls, they wouldn't schedule, and I was left to wonder, what was the problem? Was it the price tag? Was it the sedation? But when you review different approaches to treatment, minimal interventions, conventional surgical approach, I find it really opens the conversation with the parent, and you could really see what are their goals and expectations for their child's care. I have found that to be very, very beneficial. So think of what you offer in your practice like a menu. Again, you don't have to get rid of any treatments. You have something for everyone versus having just a very simple, like an in-and-out burger menu, burger, fries, and a drink. It's wonderful, it's delicious, but it's very basic, right? I think of my practice like a deli. We have something for everyone. If you want cosmetic dentistry, I have zirconia crowns. If you don't want your kid to cry when PEEP, I have sedation. If you prefer the least invasive treatment, I have SDF, I have Hall crowns. So something to fit everyone. So there's a variety of minimally invasive treatments. Of course, the focus today is Hall technique. But I can't emphasize enough that I am by no means advocating that you just run back to your practice and start doing Hall crowns. No, we want to follow guidelines on treating true dental emergencies in this time, okay? And maybe that will include a Hall crown if you need to treat an emergency patient. But just make sure you're following these interim guidelines. So most people know me as an advocate for silver diamine fluoride. That's kind of what threw me into the speaking world. And we have now the first ever evidence-based clinical practice guideline from the American Dental Association supporting the use of SDF, or silver diamine fluoride. We have a policy statement and guideline from the AAPD. So this is huge. These are evidence-based treatments. So again, when clinically appropriate, we should be offering these to our patients. But I also want people to remember SDF is not a cure-all. SDF is great. Gosh, I probably use it every day. Well, not now, but when I was prior to St. Patrick's Day, March 17th, 2020, I was using basically every clinical day. We would use SDF in some form, and it's a fantastic treatment, but it is by no means a cure-all. Okay, so it's really important for people to understand it. It doesn't restore form or function, so cavitated lesions that aren't open to saliva and can't be easily cleansed.
Jeanette, I think we just lost your sound.
It's hard. You can't hear me?
There we go.
You hear me now? Okay.
Yes.
All right. Yeah. Here, why don't I stop for a second? I see, are you responding to the raised hands?
If there's questions in the question box, that's what we're addressing. You have 3 right now. Any tips on doing side-by-side hall crowns?
I'll talk about that as we go on.
Can we have the title of the article?
I don't know which
I'll
article.
I'll ask Dr. Wingate if you'll be
specific.
more specific. That'll be great. You can see the questions. I'll let you.
Oh, this is a good question right here, is how long do treatment discussions with families take? When I first started doing this, it definitely took longer because it was not part of the norm. But now, honestly, I've trained my treatment coordinator. She does probably 90% of the discussion. So we see a lot of second opinions where they're coming from offices where they've only been given the invasive, a surgical approach only, and they come to me for a second opinion. And you know what? Sometimes, absolutely, that was the only option. Your tooth is abscess. You need to have that extracted, or pulpotomy, whatever it is. But many times they absolutely could have a minimal intervention, and my team is trained and well-versed in the minimal interventions, and they start that discussion. I'll show you, or actually I have it in my SDF lecture, but I have resources that you can download, patient education tools, videos that you can openly and readily access online at no charge. You can download it from my website, which is kidsteethandbraces.com. That'll come up a bunch of times in the lecture. I have a YouTube channel, Affiliated Children's Dental Specialists, and I have the kids and the parents looking at these materials and educating themselves. So it really is it's not adding much time at all. And even if it's a couple extra minutes here or there, you have to remember we have to give informed consent. So it's not like you have to spend hours talking about the gory details, but you can have a streamlined discussion and say, hey, your child has cavities. There's a couple ways we can approach it. We can do this non-invasive approach. We can do the conventional surgical approach. Here's the pros and cons. What are your goals and expectations? Boom, 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 and we move from there. So, there's a, I hate to call it a learning curve, but there is a little hump you have to get over where you start to get that, it's like riding a bike where it just starts to flow. So don't worry, just go for it. And someone asked about the SDF code. It's 1354 in the United States. There's a different code in Canada. I'll probably butcher it off the top of my head. I want to say it's 13600 or 1300. So sorry. All right, so let me close this out and let's move on. Okay, and you can hear me okay? Can I get a 10-4? Can you hear me?
Jeanette, we can hear you just fine.
Okay, perfect. All right, 10-4, moving on. Okay. So as far as considerations for restoring the form, function, and aesthetics of SDF treatment, like let's say your first line of treatment is a topical antimicrobial, silver diamine fluoride, not every SDF tooth needs a restoration, treated tooth. So like, let's say it's incipient lesions, hypersensitivity, you're treating crown margins or restoration margins on a tooth that's going to be exfoliating soon. Use your best clinical judgment on the age and dental age of the patient, how cleansable the lesion is, associated risk factors, like if it's at risk of fracture, what's the patient's behavior, would they still need sedation to accomplish the surgical intervention, and then of course the patient and parental preference. I love this flow chart or algorithm that Dr. Horst came up with. When you're assessing a caries lesion, is it cavitated? No or yes. Okay, well, if it's cavitated, is it cleansable? Yes or no? If it is cleansable, you could just do non-restorative therapy, like disking, keeping it clean, right? If it's not cleansable, is it accessible? Yes, well, you could do something like art or smart, right? If it's not accessible, you could do Hall crown or conventional filling. So thank you for that decision tree. I thought that was a great way of thinking about this. So smart restorations could be sealants, fillings, or even crowns, or what we're going to talk about here, the Hall technique. So just very quickly, because people ask what is SMART, it stands for Silver Modified Atraumatic Restorative Treatment, which is silver diamine fluoride, SDF, to arrest and remineralize a carious lesion, and then a glass ionomer cement restorative to fill the tooth, to restore it and further remineralize it, because it is a bioactive material. It releases and recharges with minerals like fluoride. So now, smart filling is not always the best option. If you get a tooth that's badly broken down like this, sure, you could put SDF there, buy a little time. Sure, you could put some glass ionomer there. Is it going to hold up for, how old do you think this kid is? Maybe they're 4-ish, plus or minus. Is that going to last till they're 9-10 years old and they're chewing on suckers? Probably not. So this would be an excellent example where you maybe those could be time buyers, but you really need something more durable. And now this is critically important to keep in mind. What is the evidence telling us? Well, we know we don't need SDF for the proven efficacy of atraumatic restorative treatment. Okay, if you watched my webinar for Elevate Oral Care, which should be available this week on demand, I went into ART and SMART in detail. So I hope you get a chance, if you haven't already seen that, to watch that. And it was re-recorded. I realized there was some people experienced sound issues just because of the demand on the internet. But I re-recorded it, so the audio will be perfect. So please watch that. But again, we don't need SDF for the proven efficacy of ART. Further, we don't need SDF for the proven efficacy of Hall technique, okay? The clinical trials and randomized clinical trials for ART and Hall technique, they didn't use SDF. So just remember that. You can use it. It's a great stopgap, but you don't have to have it for the proven efficacy of these non-invasive treatments. So people then question, well, what's the point? Why are you even bothering? Well, the point is, especially when we're treating children, sometimes that's all they can tolerate, right? When you have, let's say you have a squirmy 18-month-old or a 2-year-old that's all over the place and you're doing a lap exam, sure, ART has high efficacy, sure, Hall technique has high efficacy, but if they have 4 quadrants of cavitated lesions and incisors with cavitated lesions, you can't treat all of that at once. So SDF is an excellent first line of treatment. Of course, the obvious diet, hygiene, all of that. Don't think I ever forget that. That's always part of the whole package, so to speak. But as a first line non-surgical caries treatment, in that case, you could do SDF. Think of it, I like the way Dr. John Fricella explains it. Be a firefighter first, control the biofilm, put out the fire, and help stabilize things, arrest and remineralize the lesion, and then be a carpenter second. So then restore the teeth as time, money, and behavior allow. I think that's a great way to think of it. So let's look at Hall technique, which of course comes from Scotland. The most that has been published on this technique coming out of the University of Dundee, and in particular, Dr. Nicola Ines, who is fantastic. Really incredibly grateful to her and all of the work that she has done in writing about this technique and educating us on this technique. Extremely grateful for that. So Hall technique is a method for managing carious primary molar where decay is sealed under a preformed crown. We have, in the US, we call it a stainless steel crown, SSC, without local anesthesia, without tooth preparation, and no caries removal. Now, when I first heard that, I could not understand. I'm like, what? Okay, but follow along here. Clinical trials have shown it to be effective and acceptable to the majority of children, their parents, and clinicians. And this is very important because there's a lot of misconceptions about this treatment. So I like what they said here. It is not, however, an easy, quick fix solution to the problem of the carious primary molar. Like all clinical interventions for success, the Hall technique requires careful and appropriate case selection, a high level of clinical skill, excellent patient management, and long-term monitoring. In addition, it must always be provided with a full and effective caries preventive program. Yes, and this is not new. We're seeing more interest in the United States in this technique, but it's not like it's brand new. I'm trying to see when okay, so 2017, they did this Hall technique 10 years on question and answer. This is a great paper that I would recommend to read from Dr. Ines, where she shared that a Hall crown is a predictably successful restoration where a carious lesion is sealed into a tooth. The biofilm, the community of microbes, their products, and extracellular polymeric matrix is physically prevented from accessing nutrition from its main substrate, aka dietary carbohydrate. This means that the actively carious cariogenic lesion becomes a non-cariogenic lesion. Like other treatments aimed at managing carious lesions by sealing them in, a Hall crown works by depriving the lesion of fuel and making the environment unfavorable for its progression. The dental pulp lays down reparative dentin, effectively retreating in response to the advancing carious lesion. Huh? So again, when I first heard about this, I felt the same way as when I first heard about silver diamine fluoride. I was like, huh? What? It made no sense to me. I'm like, you're gonna get a crown on a tooth without prepping it? Huh? I didn't understand it. And I know there's folks that are still in that state of confusion, or maybe they have misconceptions. So I really hope to dispel that today. And let me first start by saying this, as a pediatric dentist, do you place space maintainers? I bet you do. You probably do. I do. Band and loop, lower lingual arches, right? We've probably all made and placed a space maintainer in our pediatric dental or general dental careers, right? So if you can fit and place a band for a space maintainer, you can do a Hall crown. You can do the Hall technique, okay? Because a Hall crown is just a space maintainer with a roof, right? Like a band around the tooth with a roof. That's all it is. You can do this. If you can understand indirect pulp therapy or indirect pulp cap, which I feel strongly, especially pediatric dentists, we get indirect pulp therapy. We get that. We've been doing that. We see the success of it. So if you can understand conceptually the benefit of indirect pulp therapy, you can do Hall technique, okay? A Hall crown is just an indirect pulp cap on steroids, okay, right? The stainless steel crown protects the tooth from the forces of occlusion. A good marginal seal and the cement walls off the biofilm, okay? The glass ionomer cement or RMGI cement releases fluoride and reduces sensitivity. And then the tooth, the pulp, its odontoblasts lay down a protective barrier of reparative dentin insulating the pulp, okay? Now, I mentioned how the AAPD came out with their first evidence-based clinical guideline, and they're releasing a series of these. One of the next ones was guidelines on the use of vital pulp therapies. So if you haven't had the chance to read this, I highly recommend to look at this beautiful paper. Thank you to the folks who worked on this. I mean, can you just imagine that the time, energy, and effort put into this process? Extremely valuable, but it's really an awakening, I guess you could say, to look at this and realize, because there's so many things we just hold as truths and we don't really know. And then when you really examine the evidence, it's like kind of shocking. So here they're looking at, one of the questions they were tasked with is, in vital primary teeth with deep caries lesions requiring pulp therapy, is there one particular therapy, indirect pulp therapy, direct pulp cap pulpotomy, which is more successful than others? They were unable to make a recommendation based on the available evidence, okay? They noted that there's some high success rates, but they recommend that the choice of pulp therapy in vital primary teeth with deep caries lesions should be based on a biologic approach. Okay. This is also interesting. In vital primary teeth treated with indirect pulp treatment due to deep caries lesions, does the choice of medicament affect success? I would say some folks have very strong opinions on which specific medicaments or liners or pulp capping medicaments are better or not. But if you really look at the evidence, they found it was independent of the type of medicament used, and therefore conditionally recommends that clinicians choose the medicament based on their individual preference. Okay, well, my preference is I use Fujisem 2 at RMGI. There you go. It's just as good as any other, right? Okay. So evidence, it's important to look at evidence when we're making our clinical decisions, and it's important to understand the hierarchy on the value or the quality of evidence, right? You have expert opinions, that's down at the bottom, okay? Case reports, case series, etc. But the higher quality evidence, the meta-analysis of randomized control trials, and just beneath that, the single randomized control trials, okay? We have to remember that. And there is meta-analysis showing us that complete caries removal is not necessary. I've reviewed this so many times in other lectures, so I'm going to spend very, very little time on it, but I'm just going to quickly pop through. This is from the ADA back in 2008, where they found substantial evidence that removing all vestiges of infected dentin from lesions approaching the pulp is not required for caries management. There's a Cochrane review coming to the same conclusion. Now let's go back to AAPD. In our current reference manual, you can access this online. So here's their recommendations for pediatric restorative dentistry, okay? There is evidence from randomized control trials and systematic reviews that incomplete caries excavation in primary and permanent teeth with normal pulps or reversible pulpitis, either partial one-step or stepwise two-step excavation, result in fewer pulp exposures and fewer signs and symptoms of pulp disease than complete excavation. Okay, so our own academy is saying you don't have to do complete caries removal, but there are still folks who feel very strongly about that, just depending on when and where they went to school. There's evidence from systematic review that the rate of restoration failure in permanent teeth is no higher after incomplete rather than complete caries excavation. Okay, so you don't have to remove all the caries. I could go on and on, but hopefully you get my point. Okay, I mention these papers all the time. I really hope people get the chance to read through them, but the International Caries Consensus Collaboration was a focus group of 21 global experts on cariology. So this did include Dr. Ines, Dr. Fontana, Dr. Franken from the Netherlands, who was the World Health Organization's project manager for the ART initiative. You know, these are some very smart people, but they got together to address the gap between research findings and clinical practice, because there is a gap. So I highly recommend to look at their consensus papers on caries tissue removal, caries terminology. We don't have time to go all through this, but the main point is don't be willfully ignorant. right? Just because you didn't learn this in dental school doesn't mean it's not the current best evidence. So we owe it to ourselves and to our patients to review the literature, okay? And just remember, I didn't learn, in dental school, I was taught complete caries removal, and I would fail the exam if I left caries, okay? That's how I was trained. I started dental school back in 1999, okay? There are still schools that teach this way, but it's not following the current best evidence. So you just have to remember, even if it's not what you are used to or what you were trained, just remember we used to think the earth was flat, okay? You can change. Now let's look at the evidence for Hall technique, which of course is no caries removal. There are 4 randomized control trials that show the efficacy for Hall technique. Okay, remember the pyramid? Pretty close to the top of the pyramid, the randomized control trial, right? This chart is from Dr. Ines from the University of Dundee in Scotland, just comparing these different studies. And I just want to point out that the Santa Maria paper, and I apologize, I don't know how to pronounce this last name, but the Lithuanian study, those are using specialists. So that's a misconception, as people think, well, you know, it was just done by a bunch of general dentists in Scotland. It's not really valid. No, you know, so we have German specialists, Lithuanian specialists. So, and yes, some are general practitioners in the UK, but still you're seeing high success rates compared to conventional treatment or non-restorative caries treatments. And we also have to recognize, you know, that's kind of like the dirty little secret of our current evidence for conventional stainless steel crown. Now, you know, don't get me wrong, I still do conventional crowns. I still numb and drill, not right now because we're shut down for emergencies only. But, you know, I still do conventional crown prep. I also do Hall technique. Remember, take nothing out of your toolkit. But if you actually examine the literature, you know, this is coming from, again, the AAPD reference manual, where they stated there are very few prospective randomized control trials comparing outcomes for preformed metal crowns, i.e. stainless steel crowns, to intracoronal restorations. A Cochrane review and 2 systematic reviews conclude that the majority of clinical evidence for the use of preformed metal crowns has come from non-randomized and retrospective studies. Okay, I mean, that's the reality. We all do crowns. We know they work great, but just we have to recognize that the evidence is actually weaker for conventional versus Hall technique, which is just, it's really ironic. So this is a paper from the ADA journal in 2014, where they looked at or compared conventional versus Hall technique, and the results were equivalent. Wow, okay. So what are the indications for Hall technique? Okay, so caries in primary molars. We'll talk a little bit about permanent molars as well. Per the Hall technique 10 years on, questions and answers, I showed you that paper earlier. Proximal lesions, cavitated, or, sorry for the typo there, cavitated or non-cavitated, okay. Occlusal lesions, non-cavitated if the child is unable to accept a fissure sealant. I'm just telling you what was in the paper, not saying that that's what I do. I have a good friend who gets a little bothered by that. So yeah, that wouldn't be my rule, but just saying. Occlusal lesions, cavitated if the child is unable to accept selective caries removal. Okay, now these are my indications. Primary molars with asymptomatic caries or reversible pulpitis, large multi-surface lesions, okay, like the tooth is really broken down, lesions involving cusps or extending beyond proximal line angles, where I know like a conventional restoration probably wouldn't hold up to the forces of occlusion, right? If the patient cannot tolerate conventional surgical interventions, okay, and then parent or patient prefers the less invasive treatment. Those are my indications. Contraindications, this is important. No clear band of dentin, okay, can be seen on a radiograph. That's important. Sometimes it's hard to get a diagnostic x-ray when you're working on children, but we typically can get it, whether we have the patient sit on the parent's lap or one of my dental assistants' lap, and then we have what we call a button pusher. We get a picture. I've never placed a Hall crown without an x-ray. I would be hesitant to do that. Another contraindication, signs or symptoms of irreversible pulpitis or dental infection. That is not an option. You're too late to the party, okay? Clinical or radiographic signs of pulpal exposure or periodicular pathology. Again, it's not an option anymore. And you'll have parents who come. I've had parents come for second opinion wanting Hall crown, and I just tell them, I'm sorry, it's no longer an option. Maybe 6 months ago, maybe a year ago. It is what it is, right? Crowns or teeth so broken down that they would be unrestorable with conventional techniques, okay? And this is important. Children where the airway cannot be managed safely, right? You don't want to do this in a rodeo fashion and have a child aspirate a crown. In a scenario like that, if they don't want sedation, what else can you do? You could do SDF. Maybe you could press some glass in with your finger, to buy some time, and then do the more ideal, sturdier crown later. Now, presenting this concept of the Hall crown to a parent. I think back to the question earlier of like, oh gosh, well, does this add a lot of time? It really doesn't. Initially, it might be a little awkward for you to explain it to a parent, but then it just starts to flow. So let me just give you some examples of some of the things that I say. So basically, if I'm showing the radiograph, talking to the parent, I'll say your child's tooth, the decay warrants a crown. The good news is we now have a non-invasive way to place crowns that will not require sedation, shots, or drilling. We've learned it's no longer necessary to drill away the decay. Instead, we can seal it under a crown, which will starve the cavity of the sugars and acids needed for it to get worse. And what we do is we'll use little orthodontic separators. A lot of times the parents will kind of nod and say, oh, I remember those, I had braces, to create space between the teeth so the crown can fit, instead of using a drill to whittle down the tooth to make room for the crown to fit. And then I share that studies show that the success rate is equivalent to the conventional way, the surgical way. And I would say 9 times out of 10, the response from the parent is this, like relief. Oh, that's awesome. I wish I had a dentist like you when I was a kid. I hear that stuff like that all the time, where they say, oh, they'll share their story of their bad experience, or, parents are nervous. They don't like to hear their kids have decay. They start to stress, right? They think about money. They think about sedation. They think about the pain, is it going to hurt, et cetera, et cetera. So this can be, most parents are relieved when they hear, oh, we have a new way, okay? But of course, you're going to get that parent who's like, huh, what? And they're going to question it. And that's okay. They have the right to question it. And I have the right to answer them. So if I do have parents question it, or sometimes they'll say, well, I'm going to need to go home and research it. That's fine. But one way that I explain it, I say, well, listen, what would happen if I put you in a tank of cement? Would you live or would you die? And they just kind of look at me like confused at first. And then they start to laugh and they say, I would die. And I'm like, that's right. So when I seal your kid's cavity bugs in this crown with cement, the cavity arrests and stops. It's as simple as that. I don't have to drill it out. So, this is a foreign concept to some people, but another way I like to explain it, especially when I'm explaining caries in terms of prevention and educating the parents on caries as a biofilm disease and understanding it's essentially like an acid imbalance or a pH imbalance in the mouth, and that they can control it through diet and hygiene. I like to give the analogy to the GI doctors. For many decades, treating ulcers and even some stomach cancers was a surgical approach, until these two Nobel Prize winners from Australia in 1983 discovered the bacteria H. pylori. And that dramatically changed the way our GI doctors treated the disease. It's really crazy and incredible to think back. You know, we just didn't know any better. We were doing the best by our patients to the best of our knowledge. Well, our knowledge was not accurate. Okay, so yeah, again, this is why we need to keep up with the evidence, right? What we knew 10, 20 years ago is not what we know today. Okay, so now let's look at the clinical protocol for Hall technique. All right, so here we have, this is a second opinion, hence my photo of the screen. Sorry, I realize it's pixelated, but hopefully you can appreciate that deep carious lesion on a primary first molar that's cavitated. It's not cleansable, it's between the teeth. Those are the most likely to keep growing. Doesn't matter if you put SDF on that well-into-dentin, it's probably gonna keep on growing. I can't get glass ionomer in there. Okay, so this is a great candidate for Hall technique. I can clearly see a band between the pulp and the carious lesion. So the first thing you're going to want to do is place separators, and you could use these separator pliers, or you could simply use 2 pieces of floss threaded through one of the separator orthodontic bands. This is my personal preference. This is what I like to use, and there's different sizes of the bands. There's small ones, and then there's thicker ones, and it's important to use the right size, okay? And you just judge it by looking with your eyes. So let's say you're looking at the contact between the primary cuspid and the mesial aspect of the primary first molar. That's a smaller contact. Sometimes that contact is open. Sometimes they have primate space. Awesome. You don't have to put anything. That's the best. But let's say it is a tight contact, you're usually going to need a smaller size separator. Okay, because if it's too fat and thick, it'd be sticking halfway up, getting in the way with their tongue, and it probably will fall out. So there we typically use a smaller size. Now in that broad, wide, flat, tight contact between the primary molars, there you typically need the thicker, fatter separator band to make sure that it is the width of the contact. If you try to stick something real tiny in there, or sometimes it'll slide off to the side and they come back several days later, you might not have an open contact. Then you got to need to put another band and start over. So just make sure you carefully select the proper size separator, okay? And sometimes you might need 2, sometimes you might need 1. You might get really lucky. I'll show you a case where you didn't need any because the contacts were open, okay? So I like to floss it into place. Now, ideally, if we have a parent that's on board, I like to do it right then and there at the diagnostic exam visit, right? Why not? Just takes a couple of minutes. Typically, they're already in the chair, everything's set up, so you're just adding a few minutes, okay? Now, let's say they need to go home and do their research, or they're not ready to do it that day, or more importantly, they can't come back in the frame of time you want to place the crown. If they're coming in just to have separators placed, we schedule a short 15-minute appointment. The way we treatment plan it is unspecified restorative for the tooth that it's going on, okay? And we do that at no charge. So pay attention if you're concerned with the fee for Hall technique, okay? Because sometimes this is extra time, material, and behavior management that I'm not billing out extra for. So pay attention to that if you're concerned with the fee. Now, when you place it between the teeth, it does feel tight and the kids will feel pressure. And depending on the child, some kids won't complain at all. Other kids will complain a lot because it feels tight. So we explain that to them. We're like, it's gonna feel tight. We'll say it feels like if you get a chunk of meat, you know, piece of steak stuck between their teeth, and they're like, okay. So most kids are like, oh, okay, no problem. Sometimes you will have kids that complain quite a bit, okay? And you try to redirect their attention to something else, whether it's getting their prize or their sticker and being dismissed from the appointment. So most kids, this is not a big deal, but it is important to explain that it will feel tight and pressure, and explain that to the parent as well. So they were going to want to eat softer things. And then again, it's really convenient if the parent has had braces, because they remember, I remember having my separators. Okay. And then we also send home extra spacers in a little coin envelope. We'll even thread them for the parents so they're ready to go, because God forbid one of these pops out accidentally, whether they're eating and it comes out or the kid messes with it and it comes out. That way the parent can just floss it right back in there, so we're not wasting any time. We don't need another extra visit for them to come back. So I do have videos online that you can watch of separator placement. So here's a kiddo where I'm placing 2 because she had closed contacts, so you could hopefully appreciate the smaller one on the mesial aspect of the first molar and a wider one for the molar contact. But you're welcome to watch this.
Dr. Maclean?
Yeah.
Sorry to interrupt. We got several questions on where do you buy those ortho separators? What sizes do you buy?
This is where I like to say, I just work here. I should call my lead assistant that does all the ordering, Yvette. So I honestly don't know off the top of my head. So we usually get our supplies from Benco, but I don't have a specific brand or size number, you know, so I'm sorry. I probably could find out and post it later, you know, and it's not like I can just go into our order forms, but I probably could find out exactly what they are. But
okay, some additional questions around separators while we're on this topic real quick.
sure.
When you say you might need 2 separators, are you saying that you need to place a separator twice?
When I say you need 2 is look at this kid here, okay? They have close contacts on both aspects of that. I'm going to crown the first primary molar, right? There's no space between the cuspid and the primary molar, so I need a separator there. There's no space between the primary first molar and the primary second molar. I need a separator there. So this child needed 2 separators. Okay, now as far as having to place twice, that would only be if the kid picked it out, or let's say they went and had a starburst and the food pulled it out. You would have to replace it so that the teeth continue to separate and or don't shift back together. Does that make sense? Hopefully. Now look at this. So here's a case where this child had primate space. A lot of times they have primate space between the cuspid and the first molar. There's an open contact. You won't need a separator there. If there's an open contact already, you don't need a separator. If there's a closed contact, you need a separator. So this particular child only needed 1 separator, okay? So I removed the separators, ideally about a week later. The closest I would go is maybe 2 days. I have anecdotally heard of folks saying like, oh, I just put them in the same day. It's gonna be pretty tight. So, you know, ideally, if there's close contacts, I would wait at least a couple days to a week, okay? Because that's gonna move the teeth apart and create the room to accommodate the size of the crown, okay? So you remove the separator just using an Explorer, okay? And here's with the separator removed, and you can see the space that the separator has created between the teeth, right? You can see the reddish dent, that's from the separator where there used to be a close contact. And then you can see the open pre-existing primate space, okay? So imagine that has created the space that your burr would have created, right? If you were doing a proximal slice, right? The band is doing it for you. The separator does it for you. It's making the interproximal space to fit your crown. All right, there's no caries removal necessary or needed for Hall technique. You do want to remove any plaque or food debris. Okay, at this time we are concerned with aerosol. So I'm using a slow speed tufted, like a rotary brush to clean it out. You could even just use a wet micro brush to clean it out. It's critically important to protect the patient's airway. Okay, so ideally, If you have a cooperative patient, you could have them seated in the dental chair slightly upright. Okay. I like to protect the back of their throat. I use a large 4x4 gauze that I drape across the back. Okay. You could even go so far as adhering the crown to your gloved finger with an athletic tape. I don't personally do it, but for example, it was in the University of Dundee paper, and I do know some folks that like that added sense of security. So whatever makes you feel most comfortable, and then just having them seated slightly upright in the chair. There's Dr. Ines there working on her patient. There I am working on my patient. Are we looking back at this like those hairy hands, the hairy bare hands? That's not an N95, Dr. Maclean. Those aren't goggles. I don't see a hairnet. I don't see a face shield. I don't even have a gown on. Yep, things are probably going to change for at least a while here, right? But anyhow, their protective reflexes are still in place. You can modify this if needed. Let's say for a very young patient, like here's a little 2-year-old who, you know, he's not the Tasmanian devil, but he's also not like perfectly cooperative where he'll hop in the chair. So in that scenario, I will place the child into my lap where I'm seated in the knee-to-knee or lap-to-lap position with the parent. So the parent can hold the child's hands, okay? The child can see their mom or dad or grandma right in front of them, and they are in my lap, and I will raise my chair. You know, we have the chairs that go up and down. I'll raise myself up a little higher so I'm angled above the parent, so they're at a little bit of an incline. Okay, and I have a video of this that you can see on our YouTube channel. So now you're going to select the crown. So there'll be a crown that's obviously too big and it's just kind of flopping around in there. There's going to be a crown that's obviously too small and it's not going to go down over the cusp, or especially that, excuse me, dry cough, especially not over that mesial buccal bulge. So the crown in between is just right. Easier said than done. Those are the best when you have ones where it's like it was as though the crown was custom made for them. It's not always going to be the case, obviously. Okay, but it should have a snap fit, just like you were fitting any other crown had you surgically prepared it. Okay, it should have a nice, tight, well-adapted fit. So if it doesn't fit perfectly, just like you would in any other crown you place, adapt it. Use your crimpers. Use your pliers. Let's say I need to get the seal of the margin better. I'll get my crimpers out. Let's say there's a little bit of space loss and or let's say the tooth is a little bit narrow, mesial distally, I'll squeeze it between a Howell plier. Okay, so use your crimpers just like you would had you taken a drill to the tooth. You want a nicely sealed margin. Okay, that's very, very important. Another misconception people have about this technique. It is not just shoving an oversized crown on a tooth. No, this is a well-fitted, well-sealed, nicely adapted crown. Okay, it's not sloppy. All right, now you're going to prepare your high-quality glass ionomer or RMGI cement of your choice. I like the Fujisem 2 that we mix with a spatula. I've used this cement for more than a decade. It's a great quality cement. I don't care what brand you use. I just care that you give kids minimally invasive options when clinically appropriate, okay? There are auto mixing options. This is convenient where you don't have to use a spatula. New Smile makes the BioSum. It's also an RMGI that will just mix right into the crown directly. GC has an auto mixing version as well, okay? And then you're gonna, oh, I should go back. You wanna fill it up completely, like fill it to the top. You don't wanna be stingy with your cement. Seat the crown with firm finger pressure and just ensure the airway is protected. Someone's trying to text me about the separator sizes. I'll go back to that later. Okay. You can instruct the patient to bite down. So let's say they're good at following directions, they can bite down, but you know, kids, sometimes you tell them to bite down and they're like, they look at you like you're a bulldog. So in that case, I'll use a band seater and push the crown down myself, or you could instruct them to bite it into place. Some kids don't want to bite down, so you need to push it down with a band seater. And now you're going to want remove and clean the excess cement. Okay, so floss the contact, rinse. Now, let's say you're trying to reduce aerosol, you could just use sopping wet gauze and floss to clean the excess cement. It's very important that you remove all of the excess cement, just like you would any other crown. You don't want blobs of cement left interproximally or at the margins, because that would irritate the soft tissue. So it's all the same principles and concepts, okay? Okay. And now we're done. You'll see a little slight blanching of the tissue, the soft tissue, but it's a nicely adapted crown. It's going between the sulcus and the gingiva. It's not pinching the gums. It's going along, adapting to the contour of the tooth. Okay, nice sealed margin. I do have this technique video available on YouTube. There's a link available on our website, or you can just go straight to our YouTube channel, which is Affiliated Children's Dental Specialist. Like and subscribe. But this video has now been viewed 85,000 times, which a fun fact I thought was interesting is this video has been viewed more times in a shorter period of time than my other formerly most popular video, which was the basic SDF application. So it's surpassed that by more than 10,000 views. I thought that was really interesting. So that there is a lot of interest, and it's not just dentists watching this. I have the kids watch it, because if a lot of times the kids' imagination is so much worse than the reality. So if this is helpful, I mean, I've had parents, even if you read the comments, you'll see parents comment, "Oh, this was great. It helped my kid. They're not afraid." You know, so that's the purpose of this, is as an educational tool, really for everyone. So please use this if it's helpful to you. And just remember, when we're talking Hall technique, it's truly no tooth preparation, no removal of caries, no local anesthetic. So, you know, if you're using a needle and a drill, it's not Hall crown. It's not Hall technique. You'll hear people say, "Well, I did a modified Hall." It's just an indirect pulp cap, which is fine. But true Hall technique is like nothing touched that tooth. Topical is not necessary. People have mentioned they use it. You're welcome to if you like. I personally don't put any topical. And to be honest, I find a lot of kids, like if they get upset with the topical, they say it's too spicy, you know, or they don't like the taste. So it's just one other variable that we're eliminating. And think of it this way: when you're doing your space maintainers and fitting bands or cementing space maintainers, are you using topical? Probably not. Are you using local anesthetic and doing infiltrations or block? I highly doubt it, right? So, you know, don't worry. That's another place people get hung up, and they're like, "Oh my gosh, the gums." They're fine. It's slipping between right in the sulcus between the gum tissue and the tooth. It's not really pinching or it's well tolerated by the patients. It's also important to remember that numbness does not negate pressure sensation. Right? So even if they were numb, when you push the crown on, even on a prep tooth, they feel pressure. So I've had kids that had blocks and were sedated, doing fine, you know, for pulp and crown, prepping and doing all that. But then the moment that I seated the crown, woke up screaming and crying because of the pressure sensation. So the nice thing is when you're not numb, you know, you feel pressure, but then it's done, right? They don't have to deal with that lingering numbness that upsets a lot of kids. You know, you've had the kids that say like, "Take it off," or "It hurts," because they hate that numb, the pins and needle feeling of local anesthetic. They don't like it. So, you know, if they are complaining about the tightness or the pressure, I try to redirect their attention. Some kids don't complain at all. A resilient kid will quickly and easily be directed, like, "Oh, here, look at these stickers. Look at this shiny object. Oh, let's go get your token and your prize." Now, if you have a drama queen will be a drama queen right? What else is new? And it all kind of depends on how much the parent feeds into that. And yeah, what else is new? New in pediatric dentistry? It is what it is. But some other benefits is you're not causing any soft tissue damage from nicking it with a burr. Gosh, I've seen crowns come or teeth come back for post-op, and the gum tissue got nicked up by the diamond burr, and they don't want to brush because and then it just looks raw. And, you know, that's eliminated with Hall technique. Because there's no local anesthetic, they're not accidentally biting their lip or tongue, because I'm sure that's happened to all of us at some point. It's rare, but you know, a few times a year we'll have a kid really go to town on their lip or their tongue, and that's just they're miserable for weeks, and the parents upset. So overall, it's well tolerated by patients. Now here's that same patient 2 weeks later. So see how the soft tissue looks nice and healthy. See how that crown is nicely adapted and goes in the sulcus there. Now, immediately post-op on the left, can you appreciate how the bite is opened just ever so slightly, maybe a millimeter? You can especially see between the lower cuspid and the upper lateral. You see a little space, but then 2 weeks later, the bite has self-corrected. Okay, that open bite has been eliminated. So occlusion, this is a big question, and it was one of my questions initially where I was like, huh, how does that work? So here's 2 papers on addressing that specifically. Influence of preformed metal crowns, Hall technique on the occlusal vertical dimension. The reduction of the overbite seems to be caused by intrusion of the crown molar and its antagonist. And then here's another one where the occlusal vertical dimension, OVD, returns to before crown fit levels within 2 weeks. And that's what I typically see, and mainly but not completely from intrusion of the crown tooth. So the bite does adjust. And newsflash, whenever we do a crown, even if we're prepping a tooth conventionally, the bite changes. You know, unless you're taking a scan or an impression and making a custom fitted crown, the occlusion will be slightly different with any prefabricated crown. I think we conveniently forget that, but that's the reality. So I thought it was fun to look. This is a guide from 3M with their stainless steel crowns, where, you know, even in there, they're saying, finally, the crown is checked for occlusion. The primary dentition has a great ability to adjust to a slightly open bite of 1 millimeter or so over a few days with no adverse effects. If we were fine with it before, you can be fine with it now. Okay, so here's that same patient. There's her Hall crown. It's a great service. Oop. Here she is. This girl is so cute. She loves coming to see us. She gets all dressed up, puts her biggest bow on. This is, you know, what is so great about our profession and building these relationships with kids and having them build trust in us and having positive dental experiences and a positive outlook on their oral health to last a lifetime, right? That is the beauty of what we are blessed to be able to do for our patients. So let's look at some cases. Now, this is a barely 2-year-old where all 4 first primary molars were not only hypoplastic, they were also carious. Mom did not want to do IV sedation. So I initially did SDF to put out the fire, right? There's 4 quads here. And then we did Hall technique. So here she is 5 months later. Notice now her primary second molars have erupted. Those are nicely fitted crowns. It's not affecting eruption of adjacent teeth. I should go back. Now, this is one of those easy peasy scenarios where there's no contacts. You didn't even need separators here. There were no separators used, but you have to make sure you have a nicely fitted crown, okay? And then you can see how the other teeth erupt. Look, the soft tissue looks nice. The kid's happy. She's not traumatized. This is almost 10 months later. She had some SDF and glass in the anterior. Look at how deep her bite still is. She could have done some good from opening her bite, right? But yeah, 17 months later. I mean, would you know that I had done this any other way? I don't think so. Clinically successful. Here's 2 years later. So it's a great option. I have said this earlier in the presentation, and I'll say it again. I don't care what brand you use, whether it's your Crown brand, your cement brand, your SDF brand. I don't care. It's not important to me. I don't get money off of what you use. It's irrelevant. What's important to me is that we're giving kids and parents minimal interventions, treatment options. That's paramount. That's why I do this. That's what matters most to me. I always tell you what I do use and what I like or don't like about things. But I just want to make it perfectly abundantly clear that you know, what you use is irrelevant to me. I just want you to offer these treatments and know what you're using and understand what's good and bad. So my personal preference of stainless steel crown now is the New Smile stainless steel crown. You know, for many years we used 3M. We also had a kit of Hugh Freedy, and we even have some ancient Unitech, like the untrimmed, uncrimped, because they make a size 1, right? Once in a blue moon, you need a size 1, right? Once in a blue moon, I'll have one where I need the crown a hair longer or maybe a little bit narrower, right? And if my how plier can't squeeze it mesial-distally enough, you know, that would be nice to have. But 99% of the time, these are the perfect option for a Hall technique because of how these are actually constructed. So they use a higher grade of what's called a 316 surgical grade stainless steel. So it's actually more malleable at the margins. So it's easier to place. Whether you're putting it, let's say I do a pulp and crown and I've surgically prepped the tooth, that I use this too, but particularly for Hall technique, the fact that it will flex when you seat it, it's very advantageous for this particular procedure. Another benefit is that the cost, because we were getting it direct from New Smile, was half what we had been paying for our 3M crowns. Now you see prices in general starting to change as more competition comes on the market. But remember that this is a higher quality material. Another element that I like is the sizes are actually laser etched onto the lingual or palatal aspect. It's not a stamp on the buccal like the 3M and Hugh Freedy crowns are, because a problem is sometimes you have to try in multiple crowns and of course sterilize them. But sometimes that stamp, that size stamp, can rub off and then you don't know what, you know, you have to play the magical guessing game of what container it goes in. But the laser etch does not come off, and it's on the aspect of the tooth that you're not going to see. Some people say, "Oh, well, I like that because it shows if they're brushing." I've had people who are excellent brushers, and I still had to prophy cup off the number, so that's not always true. Another benefit of that particular grade of surgical steel is holding up better to bruxing versus like a 304 food grade. Now, specific to Hall technique, if you think, you know, if you've done a lot of stainless steel crowns, which I've done, you know, in the past 15 years, probably thousands of them, you start to be able to eyeball a tooth and kind of get a gauge of what the size is. And you start to realize that the average surgically prepared primary molar is typically a size 4, right? So if you figure an unprepped will likely be on average a size 5. So that's a great starting point when you're going to select your crown size. Okay, so let's look at some more cases. Here's the one that we did at the start on when to do smart fillings versus Hall crowns, or art versus Hall crowns. So hopefully it's painfully obvious why that primary second molar would benefit from full coverage. And that was almost 2 years ago. This was that at 6 month? Okay, you can see the occlusion looks nice, the soft tissue looks nice. Sure, I could have adapted that distal margin better. I should have crimped that more. But here's 13 months later. And here, this would actually be nearly 2 months, not 2 years, excuse me, nearly 2 year. But yeah, this is a nice, durable result. And again, you wouldn't know that I had done it any other way than conventionally. Here's another doozy of an interesting case that I like to share. This kiddo, the parent had his upper arch treated at a colleague of mine under general anesthesia, but the lower arch was not done. I don't know the circumstances surrounding that, but anyhow, when he came to me, he essentially declared he was not doing sedation or general anesthesia again, and he wanted only minimal invasive. Okay, fine, no problem. We did some SDF, even those lower incisors, just keeping those clean, they'll arrest on their own. You could do non-restorative caries treatment there. But I told him on that molar, I said, you realize we have to do something more that in time with how young he is and how large that is, and it's gonna pack food, that's gonna fracture, that's gonna abscess. We need to do a crown. And I offered Hall technique and he said, okay. So you can see how the separators are placed. It creates that proximal slice that your burr would have created, and then you place the crown. This is immediately after. Happy kid, easy peasy, Superman. And then here's eight months later. There's some varnish on there, so sorry. Yeah, he's got the lovely open face crowns that were done on his top teeth. Notice that his lower incisors with no treatment, they are still fine. But this is interesting. I mentioned his upper teeth had been done under GA, i.e. ideal conditions, but things are kind of falling apart. So his crowns fell off on an ENF, so I had to re-cement them. I had this massive internal, external resorption process going on. You know, meanwhile, the Hall crown and the SDF and it was looking good. And Dad made an interesting comment. He said, it seems the teeth done under anesthesia were worse off than the ones we treated less invasively. He said that about a year ago. I was like, interesting comment, Dad. So this is just recently. He came in the beginning of March, and notice how now his upper left first primary molar that had resorption, that has now fallen out. Notice he doesn't even have the permanent first molar erupted yet, right? So that's gone. And now guess what's happening on the right side? Now he's got resorption on the upper right first primary molar, so you know what's going to happen there. And I just think this is also an interesting learning case because one of the other misconceptions of Hall technique is like, oh, what if you get ectopic eruption or it's going to impinge the eruption of the permanent molar? Well, remember, you can have ectopic eruption with natural dentition, right? Look at how that is. It looks like to me like there's some ectopic eruption going on here and some resorption happening on his natural tooth, okay? And I'm sure you've observed that before with ectopic eruption, that it can happen with natural dentition, but obviously you want a nicely adapted, a nicely fitted crown. You don't want just a big bulky thing. So, you know, why not consider this option? It's evidence-based. You can reduce overhead, reduce costs, reduce risks, have a happy patient, parent, and dentist. You can increase access to care and now reduce aerosols. The key point, Hall technique satisfies this concept of the triple aim of care, where we increase access to care, improve health, and reduce cost. But what about us? We need to be in that equation, right? So now a newer concept is the quadruple aim of care, and that includes us, the care team, the dental provider. This helps us too, so yay. So I love having this new trick in my toolkit, and I enjoyed being able to offer this to kids and to families and to dazzle them with that. This is an article I wrote last month for Dental Town magazine, so if you didn't get a chance to see it, I highly recommend to give it a look over. If you have a friend maybe who hasn't heard of this, please share it with them. But you know, these are happy, healthy, beautiful children. You know, why not? You know, why choose to overcomplicate something when the evidence has shown us it's not necessary, right? Why? And there is increasing awareness of Hall technique as an option. We have calls and emails that come in literally from all over the world. Just this earlier this week, I had a message on YouTube, a parent asking for a provider in North Carolina. This particular child, they have friends and family that are dentists. They tried to do conventional treatment on him and couldn't get past the injection. Kid freaked out. We're already having to travel to Vancouver just to be able to see a specialist, to see a pediatric dentist from where they live in this really remote area in northern Canada. But they wanted to do a general anesthetic, and mom didn't want to do the general anesthetic. She found out about Hall technique. They visit Arizona yearly, so she ended up bringing him to me, and we did 2 Hall crowns. We also did some STF. So this is after his crowns were placed. And he came back this year, and he brought his little brother, and he's still doing great. So here he is. But yeah, so hopefully you can see how he had the larger cavitated lesions on his primary first molar, smaller lesions that we treated just with SDF. But he's stable. Now there's obviously concern with occlusion. I feel hopefully I've shown you the evidence for how it self-corrects, because typically we're doing this on primary teeth. But could we do Hall technique on permanent molars? A typical adult actually crowning a tooth with no prep, not realistic. It's gonna drive them nuts, right? But you could, let's say on a young patient, let's say they have severe molar incisor hypomineralization or MIH, that is actually being investigated now, Hall technique to crown these teeth non-invasively. Now, another thought would be, this is from Dr. Horst, why not just put a band, right? It's just going around the tooth to give it support, and then use a high viscosity or glass hybrid cement. That could potentially be a temporary, at least, option for a permanent tooth. And I have even done this Hall technique in the anterior. If they have a lot of spacing, you could, and I have done this. So here's a case study. This is a kiddo with severe early childhood caries, and mom did not want him to have sedation, and hopefully you can appreciate his lateral incisors were severely decayed. And sure, you can do SDF, but there's a chance of those fracturing. So I wanted to do something more for the lateral. So I placed, with no preparation, no caries removal, I sealed the caries lesions under New Smile signature crowns. And that was sealed. Then he had trauma. He chipped his front tooth. 11 months later. Look at how cute he is. Hopefully you can still hear me. It just said my internet connection is unstable. But here he is a 1.5 years later, super cute. He loves to come and see us. 2 years later, now he gets dressed up too, and he does his hair. But yeah, why not? If they have space. And then just a little background, my postdoctoral clinical research in residency was on the New Smile signature crown. That's the pre-veneered stainless steel crown, which was, that was the game changer product that New Smile launched way back when. So I've been doing these for many, many years, certainly way before I ever started lecturing or anything like that. So I just, I had them on hand and have comfort with using them. And I'll just share that your average prepped central is an A3, and your average prepped lateral is a B4. So if you figure, if there's space to accommodate unprepped, that would be an A4 or a B5. And sure enough, I used B5s on that little boy. So this is behavior management for the Hall technique. Mom reading Hop on Pop. So he had some signature crowns and molar crowns done in the Hall technique. This is coming from the University of Dundee, just showing that amongst both the child, the parent or caregiver, and the dentist, this increased satisfaction or preference for Hall technique over conventional And this mom actually had an interesting perspective that you could watch on our YouTube channel, just comparing to her experience with her daughter undergoing a general anesthetic to treat caries versus her son being able to have SDF and Hall technique. So now let's say they don't have space. There's no spacing between the anterior teeth. You could use a strip crown form with a glass restorative. So I do these Equia Forte strip crowns. We don't have time to go to that in complete detail, but this is using, again, a prefabricated crown form and then a glass restorative. I do have videos showing that step by step, but just other options to think outside of the box. And you can use things in combination to help manage your patients, like using SDF in the anterior, which are most likely to arrest, using art restorations and smaller lesions, and then using Hall crowns for more extensive carious lesions. Now, offering minimal interventions can certainly be a practice builder. I find it, we're offering patient-centered care, so we see increased retention, increased internal marketing. I'm seeing improved outcomes, reduced stress for myself and the patient and the parent. We're increasing access to care because I can see a higher volume of patients, you know, because I'm not blocking out a whole day to see 3 kids under GA. I've got all 9 chairs open. Reduce overhead expenses, reduce recurrent caries when you use antimicrobial restoratives and treatments. You're reducing the individual cost per patient, especially by eliminating sedation. And then our new concern, reducing aerosol. And I do want to make the point, because I realize this is controversial, just because I make it look easy doesn't mean that it is. You know, I mentioned this earlier on, but I'm going to go back to this New York Times article. And the quote that they used for me is, I said, anyone can work on a patient who is knocked out, right? I mean, that's not the skill of me as a pediatric dentist, right? Like, my true skill is the behavior management, right? Overcoming the fear of the child and getting them to cooperate and allow me to treat them and build that trust with them. That's really the artistry of a pediatric dentist. The treatments we do are actually quite simple. We don't do a whole lot. It's like filling, crown. You know, I'm not Dr. Appa doing 20 veneers on a Real Housewife of Beverly Hills, right? They're kind of simple procedures. So really our true skill is the relationships we have with patients, and that's where the time and talent is especially with my training as a pediatric dentist comes into play. The child psychology. You know, for example, I like to call him patient 0, just because he was one of the very first patients I used SDF on, because prior he was literally like an exorcism to try to even just do a lap exam and a prophy on this kid. But now he's like my best friend. You know, he's had a Hall crown. You know, he loves to see me. He gives me hugs. You know, this is what I absolutely love about being a pediatric dentist. And I think that this is really our greatest skill. Now, getting the incentives right with regards to the minimal interventions, it'll be really interesting to see, especially right now when we're being told what we do is elective and we can only do emergency treatment. It'll just be interesting to see, because we already recognize, or at least this is Dr. Niederman writing this paper about getting incentives right, is dental insurance payment systems are not aligned with the current best evidence, which just exacerbates inequity. So often the effective preventive interventions, so like the nutritional counseling, oral hygiene instruction, motivational interviewing, behavior management, they're not either reimbursed the lowest, or often not at all. You know, I can't even think of an insurance I take that actually pays behavior management. You know, but I spend all that extra time, energy, and effort to place separators and coach a kid through that, and then to place the crown a week later and coach a kid through that. That's the skill. That's the time. You know, so it'll be interesting to see as we move forward as a profession, you know, how will our outcomes be assessed? Is it going to be procedure based? or outcomes based? Are we doing things for patients rather than to patients? And I ask you this, if you need to sedate a patient to accomplish treatment, sedation costs a lot of money, right? Often if you're cutting dry, you fry the pulp and now you got to do a pulpotomy. That's more money too. Should you reduce your procedure fee? So I don't understand why people think there's no special code or different fee for a Hall crown. I'm accomplishing the same thing with the same equivalent success as shown by the literature, right? That is the procedure that I am billing. So I say to bill what you do, just because you're restoring a tooth with glass ionomer, or let's say you're doing a restoration in an atraumatic fashion, it does not necessarily mean it is interim, okay? Warranty it as you would any other conventionally placed restoration. I shared this in my webinar last week, but just for example, yes, some of the things I do in an atraumatic fashion are absolutely interim. I know, for example, this tooth with severe MIH, that's going to need more than that. But sometimes my art or smart restorations, I mean, that's just as definitive as any other conventionally placed composite. And the literature, the systematic review and meta-analysis are showing equivalent success. This is billed in occlusal composite. Likewise, these Hall crowns, 2 years later, those were billed as a stainless steel crown. Okay, I didn't charge extra for the separator placement. Anyhow, okay, so we've made it to the end here. More information, you can go to these various resources that I have, my website, YouTube. I have different on-demand webinars. I hope that you take time now to between homeschooling your kids and figuring out how to keep your flat practice afloat and whether to get the EIDL loan or the PPP and how to not go insane. But take this time to be constructive, read, take all opportunities like this great opportunity from NewSmile to watch the free webinars that are out there. I have a free CE sponsored by Elevate you could do on SDF basics. And thank you so much for your time. And I just want to share this thought: to be the change that you wish to see in the world. And now I'm going to open the many questions. So I'm going to try to see.
So
sometimes they're repeated. So
is SDF FDA approved?
it is FDA cleared as a treatment for dentinal sensitivity. However, if you look at, for example, the AAPD guidelines, off-label or so-called off-label use is permissible. And, let's say, for example, you're in Canada, this is irrelevant because it's already cleared for caries, which is, of course, is what we're using off-label. If you're using fluoride varnish, it's important to understand that fluoride varnish, which pretty much everyone treating kids is using fluoride varnish, that's the exact same FDA clearance as SDF, which is for a device to treat sensitivity. Now, breakthrough therapy designation was given to silver diamine fluoride as a caries treatment, like as a drug to treat caries, which we know it is and it does. A lot of it honestly has to come down to money, and like it costs a lot more money and takes a lot more time to approve a drug versus clearing a device. So that's another story for another day. I think we might actually have a podcast from Dr. Peter Milgram. Thank you to Peter Milgram for bringing SDF to the United States, but he shared his story. Anyhow, I'm getting off topic. But, oh yeah, so NIH has funded the US-based clinical trials to prove like what we already know from all the other clinical trials that show caries arrest upwards of 90% when applied biannually.
Okay. Can you discuss the viability of placing a space maintainer immediately following cementation of a Hall crown?
Like on an adjacent tooth, perhaps you mean?
Unfortunately, they didn't specify.
If you're trying to go into the same contact space, probably not going to happen the same day because there's just not quite going to be enough space. So I know people always ask about back-to-back. Did you notice that? Back-to-back Hall crowns? Did you see that come up?
Yes, multiple times.
I personally have never placed back-to-back, meaning never a first and second molar side by side simultaneously, because again, you create space with your separator and that typically accommodates one crown, not a second crown, especially if there's space loss. So normally in that scenario, I would see which tooth is in worse condition, crown that one first, place another separator, and then bring them back to seat the other one later. That's typically how I do it. I have put Hall crowns in 4 quads all at once. Like anterior teeth, I've done multiple, you know, because there's huge spaces between the teeth. So hopefully that helps.
A lot of questions around how do you determine conventional SSE versus Hall?
Say that again?
How you're determining treatment with a conventional SSE crown versus using a Hall technique.
Oh, okay. Yeah. So, you know, whenever it's clinically appropriate, meaning you have reversible pulpitis or asymptomatic tooth, I will offer the non-invasive approach. Now, if the kid is just out of control and they need to be sedated, I would just do a conventional prep. I do minimal, you know, I basically do my proximal slice, take down the occlusion a little bit, and that's the end of it. You know, so I don't even know if I have a number on how many I still do conventionally versus how many I do Hall. I don't know, 50-50. I don't really know. Now if the caries radiographically is to the pulp, I would do conventional because I'm going to surgically prep and do a pulpotomy. And I should mention that in that evidence-based clinical guideline from AAPD on pulp therapy, the best evidence was for a pulpotomy using formicreosol or MTA. Now I know you guys you have the Neo MTA, which is the new MTA. I don't know if you want to mention, I got the chance to try it, but that it doesn't stain. Did you want to chime in with anything on that with your new MTA?
Neo MTA is a non-staining material for pulp therapy. We've had it available for several years. We just launched our new Neo MTA2 material, which is wider. It's also a little more radiopaque, still a non-staining material. For those of you that have questions about that, feel free to email me. Let's see. How do you explain potential failures in the Hall technique? I worry parents may think if it failed it is because no caries were removed.
Oh, sure. Yeah, I speak to that specifically. I don't know if you remember back to that slide where I talked that it has this, I say that the studies show similar efficacy or similar success/fail rate as conventionally prepared crowns, meaning anything I do, there's a small percent that will fail. So whether I drill the decay out or just seal the decay in, they have equivalent chance for failure. I don't really know how else to explain that, but you know, I have done beautiful textbook pulp and crown and then have them abscess. I've had one Hall crown fail, and with that particular case, the child was asymptomatic, but the x-ray, there was not a clear band of dentin insulating the caries from the pulp, but I thought, oh, if it doesn't hurt, so I'm like, okay, well, I'll try it. Like that was definitely a learning lesson, and it didn't blow up. Like I've literally had next day flared up abscess teeth after conventional crown placement. I've never had a blow up. I know that's like the term we use. Like I've never had a tooth blow up, quote unquote, immediately after SDF or Hall crown placement. It's usually a slow death. So like that one failure, it was like a 3-month process. And they had a draining abscess, and then I extracted the tooth. And there, you know, there was clearly I violated one of the principles, which is I should have had a band of dentin, but I thought, oh, you know, because sometimes the angle of your X-ray will mislead you, and you think caries is in the pulp, but it's not. But yeah.
Okay. We have several questions around what you charge and how you charge. Do you charge an SSC fee? Are you charging SDF and an SSC fee? I know there's a lot of people that have had questions on here asking about
Sure.
the application of SDF before you place the Hall crown. I know you have another lecture separate that discusses that. Do you want to address those two things?
Well, I think of SDF as a pre-treatment, and normally, ideally, let's say it's a child who can't tolerate conventional restoration due to their behavior or just because there's gross caries, gross disease, I put out the fire, and I'll treat them ideally at the exam to buy some time until behavior allows and I can do restorations if they're cavitated and non-cleansable. If I can place a restoration, I normally don't apply SDF the same day. Now, and remember, when you look at the evidence for atraumatic restorative treatment, you don't have to use SDF for the efficacy demonstrated by those clinical trials. For the efficacy of Hall technique, you don't have to have SDF. Some people will use it because, like, the example that I'll hear is it's like belt and suspenders. It's that added level of security that, okay, well, I've disinfected or remineralized or desensitized. So you certainly could, but I just think it's important to also look at the literature and show there has never been, at least not to my knowledge, a randomized control trial that compared conventional Hall versus a smart Hall. That doesn't exist. That would be a neat study, but it doesn't exist. Yeah, well, I really appreciate the opportunity to do this. So thank you so much to Mike. Thank you so much to New Smile. And thanks to everyone that actually logged on and listened live. I'm really humbled that, wow, that's awesome. So just know that I'm thinking about you guys and we're all in this together and we all love what we do and are anxious to get back. And I hope everyone takes care and stays safe and healthy. And I'll see you online.